Thank you again for having us today. We will be discussing below-the-knee CLI treatment, and we have a STEAM panel with us, which I have the opportunity to introduce to you. We have Dr. Syed Hussain, who is the chairman of the Vein and Vascular Center at Christie Clinic, and he's the assistant clinical professor of surgery at Cole School of Medicine and Cole Foundation Hospital in Illinois. We have my good friend, Dr. Mahmoud Razavi, who is the director for Center for Clinical Trials at St. Joseph's Heart and Vascular Institute in California. And we have Professor Thomas Zeller, who is the chief of the Department of Angiology in the University Heart Center at Freiburg, Bad Krozingen, Germany. And myself, Mehdi Shishabor, I'm a professor of medicine, and I'm an interventional cardiologist here at University Hospitals in Cleveland, Ohio. These are the faculty disclosures for your review. Today's program is provided by the North American Center for Continuing Medical Education and HMP Global Company, and is supported by an educational grant from Medtronic. Today's objectives, we will be reviewing the design and the outcomes reported in previous DCB studies for CLI, understanding some of the limitations and why they failed, and what was right and what went wrong, identifying important factors to consider while conducting CLI clinical trial and research and treating patients with CLI. And then lastly, reference case studies presented to optimize CLI treatment strategy with some of the case examples that Dr. Hussain will be presenting to us. With that, I'm going to hand it to Professor Zeller for his presentation. Thank you, Thomas.
Well, Mehdi, thank you for the introduction into the session's background. And it's my distinct pleasure to give you some background information before we start discussing what we could do better in the near future, performing below-the-knee trials. Well, basically, it's important to be aware of what kind of patient population we are dealing with. This is data from Japan, from IDA, from the OLIVE trial. And what we have to keep in mind is the high mortality rate over 1, 2, and 3 years, showing a mortality overall of 37% at 3 years after initial endovascular therapy for CLI. And about 50% of those patients will survive without wounds. So this is the target population. And what we need to look for is this particular population, which is undergoing major amputation or is still presenting with wounds after the initial endovascular treatment. So first of all, I will guide you through the recent multi-center randomized controlled DCB studies, trials which went wrong in a way that they turned out to be negative in terms of the efficacy of the test treatment, meaning the drug-coated balloon, which was under investigation in those trials. So the most popular and oldest study is the IN.PACT DEEP study, which was a 2-to-1 randomized study comparing the IN.PACT amphibian balloon against plain balloon angioplasty. A relevant number of patients had been enrolled, almost 360. There was an independent adjudication of all events, including angiograms, wounds, and duplex ultrasound outcomes. And this is basically the summary of the 1-year outcome, which was also the primary endpoint. We can see over here the amputation-free survival, which was by trend lower for the DCB cohort as compared to control. If you look on binary restenosis rate, it was by trend higher in the DCB cohort, whereas CLTLR was slightly lower in the DCB cohort. So overall, nothing significant different between those cohorts. This also included a late lumen loss in a sub-cohort of patients with lesion lengths up to 10 centimeters, who underwent follow-up angiogram. So if you look a little bit more close into the singular endpoints, major amputation, there was a trend towards a higher amputation rate in the DCB arm. Also for the combined endpoint, even if the difference was not statistically significant. What was the reason why this trial did fail, at least in showing no benefit in terms of the technical endpoints, which had been late lumen loss, primary patency, and freedom from reintervention? If we compare the design of the IN.PACT Amphibian, which was recalled from market after releasing the 1-year results, as compared to the IN.PACT Admiral balloon, we see that the coating technology between both brands was different. The IN.PACT Amphibian was also coated in a folded version, so that means only outside of the folded balloon the drug was located, whereas the IN.PACT Admiral balloon is coated in an expanded version and then refolded so that the entire balloon surface is coated with the anti-proliferative drug. However, what has been shown was that the major driver of the loss of biological efficacy of the IN.PACT Amphibian balloon was the balloon material. So the plastic material of the balloon was different between the Amphibian balloon and the Admiral balloon. The drug was much more adherent to the surface of the Amphibian balloon as compared to the Admiral balloon, which was affecting negatively the drug release into the vessel wall. Just recently, we published the 5-year outcomes of this study, showing more or less identical outcomes for the primary safety endpoint, which was a composite of all-cause death, major amputation, and clinical-driven target lesion revascularization. If you look on all-cause death, there was a slightly lower mortality for the DCB cohort as compared to the PTA cohort, whereas there was a non-significant higher major amputation rate in the DCB cohort. But overall, all these endpoints had not been different between the two study cohorts. Again, this is the Kaplan-Meier freedom from all-cause death through 5 years, showing that there was at least no mortality signal if a patient was treated with a DCB. So there was a 5% absolute mortality benefit if a DCB was used as compared to plain balloon angioplasty. So at least no significant difference, no signal that paclitaxel exposure was related to a higher mortality. The second trial, which was also a negative trial, including much less patient numbers as compared to IN.PACT Deep, was the BIOLUX P2 study using the Paseo 18 Lux DCB, which is not available in the US for clinical use. Again, if you look here on loss of primary patency, freedom from or TLR rate at 1 year, and amputation rate, no difference between an uncoated balloon and this particular drug-coated balloon. Again, a negative trial in terms of technical and clinical efficacy of the drug-coated balloon. The latest trial I would like to discuss, which turned out to be negative, is the Lutonix BTK randomized control trial. Even if at 6 months, the combined efficacy endpoint, which was including target lesion occlusion, clinical driven target lesion, revascularization above the ankle, amputation, it was significantly favoring the DCB at 6 months, but at 1 year, there was virtually no difference for this combined primary endpoint. And the same was true for freedom from reintervention. Again, a significant benefit at 6 months, but no difference anymore at 12 months. And this outcome was also the reason why this device was not yet approved by the FDA for clinical use in the US. If you look on wound assessment, again, here at baseline, 56% of the patients had been presenting with wounds. There was no difference during the entire follow-up rate between the two devices. If you look on all-cause death, absolutely identical survival rates, 81% for both cohorts, and also amputation-free survival, absolutely identical outcomes. So no benefit, but also no disadvantage when using the Lutonix 14 drug-coated balloon. So what are the lessons learned? Before starting a global clinical study, the device efficiency needs to be proven in an independently controlled, randomized controlled study. So a pilot study looking on late lumen loss and patency is vital in my opinion. For the IN.PACT Amphitryon balloon in particular, there had been 2 studies published, single-arm studies not independently controlled, which suggested that the device may have been technically effective, but at the end it turned out that it was not. And as a lesson learned from the Lutonix BTK trial, don't change the primary endpoint during an ongoing study. So this will include a loss of credibility for this study. So what new data do we have which tell us that paclitaxel-coated, drug-coated balloons may be effective below the knee? The first one is the so-called accredited BTK Italy study, a small single-center study again from Listro, comparing about 120 lesions treated with either the lightest drug-coated balloon with the anti-proliferative drug, which is paclitaxel again, and POBA as a control cohort. We can see here that MLD was favoring the drug-coated balloon, which is also presented here as late lumen loss, which was significantly lower if the drug-coated balloon was used. If you look on reocclusion rate, it was 8.6 for the DCB and almost 50% at 6 months for plain balloon angiography. If you look now on the total occlusions, so the reocclusion rate did differ 54% between the drug-coated balloon and the plain balloon. This was a risk ratio reduction of 85%. Important to note that the lesions that had been treated with total occlusions had been really long lesions. So this is what we are facing in our daily practice, about 24 to 25 centimeters of lesion length. If you look on freedom from reintervention at 12 months, it was clearly favoring the drug-coated balloon approach with 90% versus 58% for plain balloon angioplasty. Wound healing rate was also favoring the DCB approach, almost 90% versus about 75%. So we have 2 major outcomes coming from this study at 1 year. We have the technical endpoint, which is reocclusion rate, which was favoring the DCB, and also the wound healing, which is a major clinical endpoint. The second study is the so-called ACOR2 study from China. Again, here comparing the lightest DCB against a plain balloon angioplasty. The reocclusion rate at 6 months, 16.7% versus almost 60% for the POBA cohort, and also the TLR rate was significantly higher at 6 months in the control cohort. If you look now here on the 12 months result regarding TLR rate, again, a significant benefit for the DCB cohort, interestingly, that there is no big difference between the 12 months outcome and the 6 months outcome. Again, if you look on ulcer healing, there was no difference, only a trend towards a better performance of the DCB as compared to the control cohort, no difference with regard to amputation rates. This is now the Kaplan-Meier curve for freedom from reintervention, significantly favoring the DCB balloon again. If we compare now ACOR2 with the Lutonix trial, we can see that the lesion length was significantly longer in ACOR2, so this is more real life, and the CTO rate was much higher in the ACOR2 study. And interestingly, if we look on the performance of the DCBs in those both cohorts, the absolute numbers are very similar. The major difference was the outcome of the control cohort, which was lower with regard to primary patency at 6 months in the ACCOART study as compared to the Lutonix trial. This may be the result of the less challenging lesions that had been enrolled into the Lutonix BTK trial. If you look now on the 12 months outcome, death rate, no significant difference between DCB and PTA in ACCOART, major amputation, no difference, and CDTLR, as already mentioned, favoring the DCB approach. So what is important for upcoming studies? The key question, is patency important for limb salvage? I believe it is, definitely it is. So what can we expect with regard to wound healing following revascularization after 6 months? So wound healing rates for complex wounds are ranging from 29 to about 50%. And that means that about half of the wounds are still present, even if we do revascularize successfully our lesions. And it's also important to realize that the location of the wound is of relevant for wound healing. Heel wounds, for example, have the lowest wound healing speed as compared to other lesion locations at the foot level. It's important that we need to improve the tissue perfusion for a given time period, which is the reason why patency does matter. So we need to guarantee unstenotic target lesion for at least the time the wound needs for healing. So that means that complex wounds, which have a wound healing time of about 6 to 12 months, need a patent vessel for at least 12 months. If after wound healing, the vessel reoccludes or develops a restenosis, and the wound is already healed, most patients are free of any symptoms. We know that the loss of patency is related to limb salvage. This is a personal communication I got from Marc Bossiers from Belgium, clearly showing that with beginning of loss of patency, limb salvage rate was decreasing over time. It's often discussion that primary patency is not related to limb salvage. However, primary patency is clearly related to a continued clinical improvement. What does this mean? If a patient is presenting with restenosis, usually wound healing is stagnating. That means we have either a worsening in wound healing or a stagnation. If we then re-establish patency by a re-intervention, this results in progress of wound healing again, and in best case, in limb salvage. So what we need to really achieve is a primary patency, which does not request re-intervention. Why is this of importance? This is a case example from Ferraresi from Italy, showing that he was able to re-establish flow into the foot several times. In total, 5 interventions had been performed in this patient within a 2-year period. But if you look on the foot perfusion, with every re-intervention over time, the outflow, the microvessels, are reduced over time. So it's important to achieve a long-lasting primary efficiency with the first intervention in order to preserve also the outflow arteries. That limb salvage can result in complete wound healing has been shown by Listro in the DB8 BTK study. So reducing reocclusion rate did significantly improve wound healing rate over time. The same has been shown by Ida in a study where he did compare patients developing restenosis in orange compared to no restenosis over time. And you can see here wound healing was about 100% in lesions that did not develop restenosis as compared to 59% at 3 months and 80% at 12 months. Also, ambulation was much better if the target lesion did not develop restenosis over time. This is a retrospective study looking on the outcome of femorocrural bypass, also showing the value of patency. So the bypass graft with the highest patency rate, which is autologous venous bypass graft, did show the highest wound healing rate. Besides that, direct revascularization by Trent did also show a better wound healing rate. From the same study, the development of new wounds was related to restenosis or reocclusion development in the same angiosome. And the best patency again was achieved with venous bypass conduit, which had the lowest redevelopment of wounds over in a mean follow-up time of 7 months. Some remarks regarding drug-eluting stents. Are they first choice for focal BTK lesions? In my opinion, they are, as shown over here. This was a total occlusion of the TPT. In the meantime, we have 3 randomized controlled trials clearly showing that drug-eluting stents are superior either to over plain or uncoated stents or balloon angioplasty as control cohort used in the Achilles trial. A patent vessel also was related to a significantly reduced reintervention rate and to a increased wound healing rate. In the Yukon trial with a 2-year follow-up, we could even show that the event-free survival was significantly improved for the sirolimus eluting stent, and also the combined major and minor amputation rate was favoring the sirolimus eluting stent over a bare metal stent. This is a meta-analysis of the 3 randomized controlled trials, again showing a clinical benefit in terms of improved wound healing if a patent vessel was present after drug-eluting stent placement, and also event-free survival highly significantly improved over bare metal stent or plain balloon angioplasty. What else matters besides patency? It's already mentioned the angiosome concept, the number of BTK vessels that are reopened, infection-controlled wound care, foot surgery, offloading, and diabetes control. I will close my presentation with 2 additional slides showing that if we follow the angiosome concept, that means that we reopen the vessel which is providing the wound-related foot or wound segment with blood flow. If we open those vessels in diabetic and non-diabetic patients, in particular the patients with diabetes, have the highest benefit from this direct revascularization approach. And in addition, we open more than one single vessel. This also is related to a higher wound healing rate. I thank you for your attention, and I believe that we have now enough data for our discussion.
Professor Zeller, thank you so much. As always, you give us a very comprehensive and detailed overview of the data. I think you set the stage nicely for a nice discussion. I wanted to start, there's so many things I wrote down I want to ask and learn from you guys, but let's first start with this idea of patency. You mentioned and you showed a lot of data related to the importance of patency for CLI. To me, I think there's a misnomer out there, and I was going to give you a break and maybe start with Dr. Razavi, see what his thoughts are in regards to what's the difference in patency between claudication, where we're dealing with SFA, versus CLI. As you know, many have said that, well, once the wound heals, the patency is not that important. So to me, there's 2 patencies: patency while the wound is present, and then patency after the wound heals. Your thoughts on the issue of patency, Dr. Razavi?
Yeah, no, I agree, but I also agree with Professor Zeller that patency and blood flow to the area of a wound is important. Now, and obviously, claudication and CLI are 2 different disease entities, 2 different sort of natural histories, and involving different vascular beds, obviously, that have different biologic behavior. But back to the patency. Patency is important. We have to establish flow. Revascularization is fundamental to treating the patients with critical limb ischemia with wound. And so that means we have to keep the flow going. The one thing I wanted to mention with regard to patency and the clinical trial is that while regulatory agencies tend to focus on clinical outcomes, appropriately so, those of us in the international arena or revascularization arena have to consider the fact that the clinical outcomes are multifactorial. There are multiple factors that go into the development and healing of the wound or survival. What we need to be focused on is, and since the revascularization adds incremental value to that process, we need to be able to measure that incremental value. And for us, that's morphologic assessment. So patency is very important.
Yeah, thank you. I wanted to ask you guys a question, and start with Dr. Hossein, related to, forget about the regulatory issues for a moment. As a physician that treats patients with CLI, what are the two things that you think are important to you in order to pick up a new technology, to engage with a new technology like DCB, let's say, as we were focusing on for below the knee?
I think for below the knee, that's kind of the Achilles heel right now, is we don't really have a good option for below the knee treatment. You know, I think at this point, I personally, despite the data I know that I've seen coming out of Europe, I have not been overwhelmed by, I would love to use drug-eluting stents if I could. You know, I think that definitely does show the best outcomes. But unfortunately, in the United States, we don't have access to that. So if someone told me today I can use a drug-eluting stent down in the tibial vessels, I think I'd be very excited about that. And I really believe, I think, just in my own anecdotal experience, and of course what we've seen in Europe, to really change the outcomes for these patients. And they really do have durability long-term. I think this below knee concept is a little bit controversial, at least in the United States. I think for a long time, people feel, well, you know, if the patency is not as good, you can always bring the patient back, you know, and if you see the wound is not improving, you can re-intervene and try to improve flow. We just saw from Dr. Zeller's presentation that you end up losing vital collaterals over time. But I think that when you have these wounds down there, just like Dr. Razavi said, there are so many different factors that influence wound healing. So for me to say that, well, the patency is the reason the wound healed is a little bit, I think, of a misnomer. I think that what kind of care is the patient getting in the wound center? I don't know if all of you here treat your own wounds or not, but I typically send my patients to the wound center. So once I revascularize the patient, how they're showing up to the wound center, are they showing up for their appointments on a regular basis? Are they getting the latest therapy for wound dressings and things of that nature? All of that sort of changes the outcome. So I think from my standpoint, I think those two technologies would be probably the biggest things that would change my practice currently. I think there is promise for drug-eluting balloons, but I think the thing that would really hit the buck the hardest would be the drug-eluting stents for me.
But let me push you a little bit, because we want to make it a little bit exciting here.
Sure.
And so I guess what I'm saying is that what would it take if I'm out there, a company, and I'm thinking of developing a new drug-coated balloon, and I'm interested, to know what would it take for physicians to take this technology, to take up this technology? Because as Dr. Zeller showed, you're not going to impact amputation, that's for sure. Wound healing, well, maybe time to wound healing, but I don't know. So far, we haven't seen a lot of promise. Maybe there is something there. I don't know. We can discuss that. So is there anything else related to patency or TLR that would convince you? And the answer may be no. I just want to know what's your take. Is there anything that they could do to convince you that, what is worth paying 10 times more, 20 times more for one technology over the other, for you to take up that technology?
I think right now, currently, generally speaking, for vascular surgeons, and I think for most interventionalists in this country, I think people focus a lot on patency. Patency is probably the most important thing, but people want to see a randomized controlled trial against an established therapy. That's what they want to see. So for example, when we talk about atherectomy and we talk about it in a vacuum, or we talk about it compared to just plain balloon angioplasty, that doesn't motivate people to really use atherectomy. I'm just throwing that out there, okay? But you can talk about that with any other technology. People want to see drug-coated balloon catheter therapy versus using a stent. People want to see drug-coated balloon catheter therapy using atherectomy and DCB combined. Those are the kind of things people want to see, is those really hard-nosed trials that unfortunately we never really see those trials, you know, and I think that's why you see so much dissension in the vascular community in general. When you go to the meetings, people are arguing from all aspects because everybody wants to see something that makes a real hit, you know, and that's frankly my opinion on that.
Dr. Shishiver, you mentioned amputation. I think it should be mentioned that amputation is an insensitive measure, primary endpoint outcome for what we're talking about. We need to be able to measure incremental improvements, then add all of those together to turn into a clinical improvement.
Absolutely. So let's talk about that, because I was fortunate enough to be on the FDA advisory board related to the Lutonix. And I tell you that the biggest challenge for me to understand is that how do you objectively, in a setting of a clinical trial and regulatory, approval, define clinically driven TLR in CLI? Because focal education is relatively objective. Still, there is some subjectivity to it, but I think there's reasonable objectivity when it comes to SFA. For below the knee, because of difficulties in assessing the patency, and most of the trials have been open or closed. The velocities have not been that accurate with ultrasound. We know the limitations of that. And then the clinical part, clinically driven part, has its own challenges. Tomas, what is your advice? Because that's the one I honestly myself haven't been able to get my hands around. How do you define objectively clinically driven TLR, which is the thing that you showed that made the difference in most of even the promising trials by Listo and folks in Japan?
Yeah, well, basically clinical driven TLR in CLI is basically defined by the patient's symptoms he's presenting with. That means if a patient with wounds does not present with satisfying wound healing speed, this makes you suspicious for the presence of a restenosis. If it's confirmed, then it's clinically driven TLR. A patient who has still rest pain or is developing again rest pain in the presence of a restenosis or reocclusion, that's clinically driven TLR. Everything besides that, basically simply detection of a reocclusion, restenosis without clinical symptoms, that's TLR, that's not clinically driven. So the patient is the one who is clearly defining what is clinically driven and what is simply a TLR. Yeah, probably with the intention of avoiding prospectively development of new wounds or something like that.
I guess the challenge, I'm thinking in my own clinical practice, that many times that patients come back with a worsening of wounds, and it turns out that, there are multifactorial issues affecting the fact that the wound is not healing. So that's one issue. The second issue is that, where is that objective concern, right? There are, sometimes the patient comes back and the wound is not looking great. You find out, oh, the patient was stepping on the wound or was not, offloading or something like that, or there's a lot of edema. And so do you believe that these, the concept of clinically driven TLR should it be directed by the whole lab when it comes to wound? Rest pain is easy, right? If the patient has rest pain, well, then that's easy. But I'm talking about wounds, right up at 5, maybe even 6. With wounds, do you suggest that, the core lab should be driving that, measuring these wounds every time the patient come back? And if they're going the wrong direction, there should be an automatic, duplex or some kind of imaging? What are your thoughts about that?
It would be helpful, definitely, if we would have, or if we would have a kind of objective measurement of wound size, not only related to the wound area, but also wound depth. That would be very helpful to guide us whether it's really indicated to, for example, perform a re-angiogram in terms or in cases where duplex ultrasound is not really diagnostic. Still, regarding the definition of a clinical driven TLR, as soon as a wound is not healing, and we confirm that there is a restenosis or reocclusion of the target lesion, this is definitely a re-intervention which is clinically driven, regardless whether the wound care was appropriate, regardless whether offloading was appropriate, because our intention basically is to guarantee best possible perfusion. That means the basics for adequate wound healing based on best medical practice related to wound care. So in the absence of sufficient blood flow, even the best wound care cannot result in sufficient wound healing.
Absolutely. Let me move to Dr. Razavi. And Dr. Razavi, you're going to comment on this?
Yeah, I was just going to say some of these measures, they need to be standardized. So until they're standardized, presence of core labs are important, because that's what happens during these trials. And then once that happens down the road, and everybody sort of has a standardized way of following these patients, then one could do away with that. But initially, at this stage, since we're learning all together, presence of core labs are very important.
Let me, Dr. Hossein brought up a good point, and I'm going to ask you, Dr. Razavi, about this. He brought up the point of atherectomy. He mentioned something about that, and this issue of, there was a lot of excitement, and I think there is still a lot of folks out there that practice this concept of DARTs, right, in the SFA. Atherectomy plus, anti-proliferative therapy. Do you think there is a role of this in the below the knee, and are we too rudimentary? Again, forget about regulatory first, because when you start adding devices, then it gets very complicated from a regulatory. But clinically, do you think we are we are approaching this in the wrong way, and we should be more aggressive, doing more complex patients, like we saw with Listro versus Lutonix, for example? He had much more CTOs, much longer lesions, but yet the outcomes was much more better. And utilizing multiple devices rather than just relying on one or two. Should be moving more aggressive trials versus simple trials.
Well, we should, but we also need to understand the incremental effect of each. And combination treatments are, without a doubt, the way to go in complex situations such as critical limb ischemia. But we need to make sure that we don't take our eyes off of the cost of treatment. One of the problems with in this space is that if the cost of treatment, and that's real, if that becomes more than, to a point where cost effectiveness becomes a big issue, which currently is, then we lose the ability for these multiple expensive treatments one in a row, one after the other. I think we need to make sure that is that kept under control. But I also want to mention, you brought up the issue of TLR. TLR, whether it's subjective or objective, is important to payers. Because that's where the cost is, right? So TLR is an important measure in these trials that we need to keep an eye on. And back to your question, multiple treatments or combination treatments, I think that's where it's going to be at, but we need to be very conscious of cost.
I guess
Dr. Shishabur?
Please, Dr. C.
Yeah, I'd like to ask a question, and I think Dr. Razavi and Dr. Zeller brought up some very good points about that. One of the conundrums that I feel like we run into a lot is the cost issue, and I think when I look at treating patients with critical limb ischemia who have non-healing wounds, and this idea of clinically driven TLR, it varies so much across the country, right? And all of you have seen that, doing tibial ultrasounds and the duplex study on the tibial arteries requires a very good skill set versus doing an SFA or popliteal artery. So most of your labs where you are getting results from are coming in from people who have very good results with FemPop imaging. But the minute you get below the knee and you're doing velocity assessments and gradients and things of that nature below the knee, it becomes very shaky. So it kind of depends on your volume, how much the technologists that are doing these tests are able to actually pick up on the disease. So I'm just curious to know what you guys currently do in your practices now, Dr. Razavi, Dr. Shishabur, Dr. Zeller, because currently for me, when I see someone come in, I am clinically looking at how they're doing. And if the wound is not improving, if the wound is not getting smaller, or if it's stagnant, that tells me that I probably have a restenosis. I may get an ABI or a TCPO2, verify my beliefs, but generally speaking, that's kind of the direction I lead in. So I'm just curious to see what all of you do currently right now.
Well, standard of care in my institution is measuring TBIs. And of course, we are doing duplex in all those patients, even if you mentioned correctly that in some of those cases, it's non-diagnostic because you have the shadowing of the media calcification. So you have no clear visualization of the target lesion, but at least usually you are able to measure the flow at a distal segment of a given tibial artery. And doing this, you can see whether you have a biphasic post-occlusive or post-stenotic Doppler profile, or if you have a normal 2 or 3 phasic Doppler signal. So with this, you can indirectly diagnose restenosis or a patent vessel. This is semi-quantitative, of course, and if we have some hints that there is reocclusion, that there's stagnation of wound healing, then of course we ask the patient to come back into the lab and we do a control angio ready for reintervention.
Can I mention a quick note here is that in this patient population, I think we all need to be cognizant of those people who are healing late or delayed, and that is concomitant existence of venous outflow disease. These patients, about 20% of them will have that because they have history of DVT, reflux, all of that. And those need to be addressed also. We actually do screen our patients. That is something that's not done in the current clinical trials, but we do screen our patients for venous outflow disease or reflux so to address them. It's not uncommon.
Yeah. Absolutely, and I think that you're raising a good point that we need to be multidimensional in these approaches. I think that we are thinking about the ideal state, right? The ideal state is that we are not let's say having a low threshold to take people to the cath lab. I can tell you that we published a number of studies showing the limitations of current perfusion assessment in CLI. And then after a couple of years, folks in Michigan from Blue Cross Blue Shield published a paper kind of, confirming our findings. But what was more interesting in their paper is that 50% of physicians in Michigan under Blue Cross Blue Shield do not do any kind of a hemodynamic or duplex ultrasound assessment. If they have a patient with CLI, they take them directly to the cath lab because they don't trust the numbers. They don't trust ABI. They have concerns about ultrasound, as you highlighted, Dr. Hossein. The TBI, is not reimbursed. It's difficult to do. People have ulcers on their toes. They can't get toe pressure, and all these things, I guess. And so that was really alarming to me that actually people would just directly go to the cath lab. So I do think there is that in the clinical practice is easier to get your hands around clinically driven TLR in setting up a regulatory clinical trial where you're trying to minimize bias. And when things are not blinded, you can see how, that can play a, kind of a little bit of confusion. Anyway, there is so much more to talk about. Maybe I ask one more question, but I think we are running out of time and we want Dr. Hossein to do a case presentation. So I ask one more question. How important in the setting of a clinical trial do you think it is? And maybe I start with Dr. Zeller. How important do you think is the heterogeneity of care? Meaning that, especially from a procedural standpoint, let's forget about the other stuff. Because you see Listro's work, and we all know him. He's a good, he's a very good operator, and obviously he's very committed to CLI. You see his work, and then we see other data. They don't chime together very well. And despite the fact that he's doing more complex cases, if there are folks out there that want to do clinical trials, how important do you think that is, Tomas, for them to take into consideration?
Well, heterogeneity with regard to wound care cannot be excluded in any upcoming CLI trial because politics regarding how to deal with wounds are different in every institution. So this is something we have to accept at the end. But I don't believe that this is the major point because clinical reality reflects exactly this situation, that wound care is done different in every institution. So if we would like to talk about study outcomes that can be generalized for the general population, we have to accept these differences in wound care approaches. So this is simply how it is, and this is what we have to deal with. Important is that we have a kind of balance of centers with potentially different approaches to wound care. Well, so that there is no significant difference between the study cohorts in terms of randomization. So that would mean that each center needs an individual randomization to guarantee that within a given center, the numbers between the test and control cohort are comparable. This is probably the way to exclude an impact of different wound care strategies on the outcome.
Absolutely. I think with that, Professor Zeller, if it's okay with everyone, we're going to ask Dr. Hossein to do a case presentation, which is going to highlight all the challenges that we have discussed. And honestly, an hour is never enough to discuss CLI. It's such a complex. I just hope that folks out there don't get discouraged. It is a very challenging area, but it's also very rewarding because we're trying to do limb salvage. And so I hope that folks don't get discouraged. I think the data from EchoArt is very promising. It looked very good despite the complexity. And I know that there are others out there that are trying to pursue this area, which is not easy. So Dr. Hossein, I think you have the slides now. They're going to put it up for you, and we look forward to your case.
All right, so I have two cases today. So this is patient number 1, 68-year-old gentleman with a non-healing ulceration to the right great toe after an ingrown toenail therapy. Relatively common problem. The podiatrist sent the patient over because the wound has been present for almost 4 weeks now with drainage, but no evidence of any cellulitis or any type of gangrene or any evidence of fevers or chills. The past medical history you see listed there is pretty standard for any vascular patient with insulin-dependent diabetes, heart disease, COPD, and a history of tobacco use disorder. From the standpoint of the physical examination, the patient has non-palpable pedal pulses in the right and left foot. On examination, there's minimal serous drainage from the toe, but no bleeding or foul odor is noted, no erythema or cellulitis is noted. The arterial Dopplers on the right side are 0.34 with a toe pressure of 37 millimeters of mercury. The dorsum of the TCPO2 of the foot is 26 millimeters of mercury, which is non-consistent with healing. The left ABI also similarly is diminished to 0.67 with a toe pressure of 71. A duplex examination was performed. There's a patent femoral popliteal segment on the right side with an above-knee popliteal velocity of 277 centimeters per second with a ratio of 2.9. The minimal flow noted below the knee in the distal posterior tibial arteries, and the peroneal artery is not visualized in this patient. So these are the pictures before we started. So you can see that there is a slight tapered stenosis here in the distal SFA. It's not terribly significant, but definitely sort of correlates with what we saw on the duplex examination. And here's your distal P1, P2, and P3 segments. Some mild irregularity, but essentially these are patent. And then when we get below the knee, this is what it looks like here. The anterior tibial artery is occluded. Tibial peroneal trunk is stenotic with the posterior tibial artery that's occluded. And then there's a peroneal artery that has multisegmental stenosis throughout its course. So in this particular case, we used a command wire, a 0.14 command wire to get across the occluded posterior tibial artery. And then I decided to use a SXT device, small device, to do my atherectomy in the tibial vessels here. So you can see this is the first pass. Typically when I do these passes, I tend to use just one pass and then shoot a photo. If I'm feeling overconfident, I'll do 2 passages. And you can see we were able to get down to the mid portion and then into the distal portion of the posterior tibial artery as well. So you can see the device jump there a little bit. And this is all the way down by the ankle in the posterior tibial artery. Afterwards, I did a balloon angioplasty using a nanocross balloon, both the posterior tibial and the peroneal blood vessels. So on the left side, you can see we did a angioplasty of the peroneal artery, and then we did an angioplasty of the entire posterior tibial artery as well. So these were the pictures after we were finished. This is the pre-picture, the first one. The one in the middle is right after we intervened, and you can see we have a nice patent peroneal and the posterior tibial blood vessel. And then this is down by the ankle. You have a nice patent posterior tibial blood vessel into the foot. And this was the lesion that the patient initially presented with. So this completely healed within a matter of about 2 weeks afterwards. So it was a simple ingrown toenail surgery that was sort of went a little bit awry due to lack of pedal pulses on this patient. This is a 76-year-old male, non-healing ulcers on the right, first, second, and fourth toe, the dry gangrene, foul odor, but again, no drainage or erythema was noted. The wounds were persistent for over 10 weeks, and podiatry has done multiple different debridements to this to try to get it to heal. Past medical history, again, remarkable for insulin-dependent diabetes and tobacco use disorder in the past. Upon physical examination, non-palpable pedal pulses once again. Dry gangrene was noted on the toes with some erythema and tenderness, but no drainage was appreciated at the time of examination. The right ABI was 0.38. Toe pressures were 26 millimeters of mercury on the right side, and the TCPO2 on the dorsum of the right foot was 8 millimeters of mercury, so definitely no blood supply to the right foot. Duplex examination was performed. Again, a femoral popliteal segment was completely patent with no evidence of any elevated velocities, and minimal flow was detected within the tibial vessels. This is an example of a duplex examination that was done at an outside hospital about 80 miles away from where we are at. And their technologists had a very difficult time visualizing the tibial vessels. They thought that they saw flow in the anterior tibial artery, but they weren't sure. But the tibial peroneal trunk to them looked occluded. This is the photographs of the images of the patient's feet. And you can see the extensive dry gangrene in multiple areas of the foot here, and also on the plantar aspect of the foot as well. So this was essentially the below knee angiogram, and you can see here the anterior tibial artery is occluded, the tibial peroneal trunk is occluded, the posterior tibial artery is non-existent. There is reconstitution flow in the peroneal artery, and you can see the runoff picture. The peroneal artery comes down, and then there's an anterior communicating branch giving rise to the dorsal pedal artery in this case. So I was able to get across the anterior tibial artery in this case with a command wire and a supporting catheter, which is a Trailblazer catheter, which is what I typically use in my lab. And once I was able to get across that with the 014 wire, we decided to do a SXC atherectomy with a small device, Hawk 1, and we ended up being able to get across it. And in this particular case, again, I dotted the artery first to make sure the device crossed all the way down. I did not need to do any type of pre-atherectomy angioplasty in this case. So again, you can see the device jumps a little bit as it goes through some of the tight areas. And we're able to go down to the mid-anterior tibial artery with the device. And this involved mainly one passage to establish just a luminal channel because the device is quite large. Able to get down to the ankle where the artery once again reconstitutes. I pulled the wire back after I treated it with an angioplasty, and then I was able to get across the tibial peroneal trunk, and I treated the TP trunk here with the atherectomy device as well. So this was our pick after the first TurboHawk passage through the anterior tibial artery, and you can see you actually have a nice flow channel here in the peroneal blood vessel, and then you have a nice channel here in the anterior tibial artery that we didn't have before. You have a big dissection plane here in the proximal peroneal artery. When I re-entered, let me do that one more time. So this was our picture here after we did the atherectomy in the peroneal artery. And I tried to see if I could extricate that dissection flap through the peroneal blood vessel by passing it the second time. But you can see I still had a dissection flap here. It was improved. The flow was much nicer. But again, the dissection flap persisted. So we did a balloon angioplasty with the nanocross balloon catheter. And then this was our final image here after we were all finished.
Well, thank you again, Dr. Hossein. These are unbelievable cases. You know, it's impressive how you're able to manhandle the TurboHawk and get it all the way down to the ankle. And your technique is very nice technique. The results are excellent, and we appreciate you showing these two cases. Thank you again, everyone. This concludes our presentation. I'm grateful to our panelists for their contribution. I hope you enjoyed the discussion, and I learned a lot, and I hope you also learned some of the challenges as we try to tackle patients with critical limb ischemia. Thank you.